Hey everybody, so this is the video, one of two videos for Study Guide 2. There was so much material to cover this week that I decided to break it up into two study guides. There's a lot of review, right? A lot of reading. It's kind of overwhelming probably, especially because you've got plenty of other things to do this month. This is a neurosurgery rotation. But remember, as you're reviewing the neurologic disease stuff, remember to use the study guides, use these videos, use these cases to kind of help nudge you toward what is higher yield, what is more important. A lot of these things that we talk about, like the different dementias, the different demyelinating diseases, the different kind of movement disorders, really, you should be okay if you just kind of briefly read through and get the lay of the land, remind yourself, what is this again? What is this disease again? How do I differentiate Parkinson's from normal pressure hydrocephalus, from corticobasal degeneration? Think through like that. But focus on, the things that I kind of nudge you toward here and there. And you may not get through all of this material this week. That's life, right? We get busy. We don't get to everything. That's okay. As long as you're able to get through all of this by the end of the month, you should be fine. If you need to, watch this video before you've studied everything that's on the study guide, that's fine. You can do that. It may not be as helpful, but you may still get a lot out of it. Just be sure that you try to make it active and still try to give answers, hazard a guess, even if it is totally a guess. Because when you are an active learner, you're going to retain it better. You're going to just manipulate that material better in your brain. It's going to stick better, and things are just going to make a lot more sense. So my hope with these cases, again, is just to kind of flesh things out a little bit, guide you towards some important concepts and diseases, and then also to try to make it a little bit more engaging, so that you're not just reading a neurology textbook. Okay, so we've got, I think, 3 cases in this video. Here's the first one. So already you kind of know what realm we're in from the title, but we've got a 70-year-old man who's been falling down a lot. He walks hunched over with short, shuffling steps. This is probably setting off ringing bells in your ears. His wife says his voice has changed over the past years. His voice is soft and it's flat, it's monotone. His handwriting is small and cramped, and that's new. So he ends up seeing a neurologist who notices other things on exam. The patient is got some cognitive issues. So on the mental status testing, the patient has some issues with orientation. The neurologist does a 3-word recall with the patient, gives him 3 words to remember, and then 5 minutes later asks the patient to repeat those words. Patient can't remember any of those words at 5 minutes. The neurologist notes that the patient's speech is dysarthric, and as we mentioned before, he notices also something about the patient's movement, that the patient just does not move much, doesn't have a lot of spontaneous movement. For example, the patient doesn't blink his eyes very much. Patient doesn't swing his arms when he walks. He doesn't use gesture. He doesn't alter the tone of his voice. He doesn't use a lot of vocal animation, which is movement as well. And so the patient just kind of sits there with a flat affect. He masked facies is the term you'll hear mentioned. He has some rigidity in the right, more than left extremities when the neurologist is assessing tone. And then there's the presence of a resting tremor in both upper extremities, but more so in the right. So we've got a little asymmetry. Again, we see movements are not just rare, but when the patient does go to move, for example, when he's doing finger-nose-finger testing, his movements are restricted and slow. He doesn't quite go all the way, and his movements are very slow. He has a stooped posture, really loses his balance quite easily if you come up behind him and kind of pull him back. Again, his steps are small and shuffling, and as he walks, he doesn't really swing his arms, and in fact, you start to notice some tremor in his right hand when he walks. So give your differential diagnosis here. I think we're all kind of thinking one thing, but let's be creative. Let's think of some other things. Let's see if we can think of at least 3 other diagnoses here, okay? So pause, get your pen, get your paper, write down at least 3 other things if you can, or 3 things that could be your diagnosis here, and then come back. Okay, before we talk about your answers, though, I just want to remind you the 4 cardinal features of Parkinson's disease. So bradykinesia, this is the one that we tend to understand the least when we come out of foundations. It's hard to describe, right? But it's basically this paucity of movement and this restriction of movement. And it's so striking in these patients. So patients just don't have a lot of voluntary movement. And that can include even just blinking their eyes, moving their articulators a little bit more so they can alter the tone of their voice, gesturing, all these things that we do without really thinking about it. Facial expression. So there's just not much movement, and when there is movement, it tends to be this kind of small movement, as we see with his step, as we see with his writing, as we see with his speech. Rigidity, so you guys remember lead pipe rigidity is one of the features of Parkinson's disease. So you palpate or you feel it by ranging the patient's joints, passively ranging the patient's limbs, the major joints. Especially the wrist is a good place to feel it. Resting tremor, so again, the wrist is a good place to feel that. And the combination of the tremulousness and the rigidity can kind of give you this cogwheeling effect. So we call that a cogwheel tremor. Postural instability. So these patients are really quite unstable, fall very easily. They kind of get pulled to one side. Suddenly they can't quite right themselves and they fall very easily, whereas the rest of us can kind of compensate. So, some neurologists argue that if you respond to Sinemet, which we'll talk about in a moment, that too really is a pretty strong argument that you have Parkinson's disease, as opposed to some of the other diseases we're going to talk about here that don't really tend to respond to Sinemet. Okay, so here's my differential diagnosis. I am sure you guys can think of others. Maybe this one's a little bit overboard because I was setting us up to talk about some different topics, but I can tell you right now, looking at this differential diagnosis, I would jettison essential tremor right away, right? None of us think this man has essential tremor, but I put it in there because that's an important thing for you to review. Why is it not essential tremor? Well, obviously he's got a lot else going on besides tremor. And the other thing is that, as you recall, essential tremor gives you more of an action tremor than a resting kind of a tremor. But it's important for you to read about essential tremor, it's very common, so you're going to encounter it. And it's maybe on your exam. And you may actually even see a patient get deep brain stimulation this month for essential tremor, as that's a treatment for essential tremor in addition to Parkinson's disease. Okay, so normal pressure hydrocephalus, that's probably pretty unlikely in this man's case. So sometimes NPH can look a bit like Parkinson's, mainly because patients get this magnetic gait where they can't really even lift their feet off the ground, and it can look very Parkinsonian. Of course, these patients can have dementia, we know that, and they can have urinary problems. So, what is that mnemonic that you guys learn in foundations? Wet, wobbly, wacky. That's what you should think of when you think of normal pressure hydrocephalus. The other thing you should think about with normal pressure hydrocephalus is that it's potentially something that's treatable. So unlike most of this stuff here, it's something we actually have treatment for. And so, if you identify it, that's good, because you may be able to help the patient. So we always try to make sure if it's there, we identify it. Okay, and then you have this, I'm going backwards, by the way, as you can see. Then we have this class of Parkinson's plus diseases that always come into play when we're thinking about diagnosis of Parkinson's disease. And they all have a little bit different flavor depending on, what part of the brain their disease process is in. These are all neurodegenerative diseases. I think if you just kind of touch on the main points of each of those, kind of just remind yourself what they are, you should be good there. And then the other thing, so since we're going backwards here on my differential, the other thing to think about, and this probably is the strongest possibility besides Parkinson's disease in my mind for what's going on with this man, is something called secondary Parkinsonism. So strokes, cerebrovascular disease can cause you to have Parkinsonian symptoms. If you have injury to your basal ganglia, from something like microvascular disease or an ischemic stroke, you can get Parkinsonian findings on exam. And sometimes can be pretty dramatic. Sometimes, we'll try Sinemet in these patients, and they don't really tend to respond like patients with Parkinson's disease. So one of the other things that can cause a secondary Parkinsonism is medications. And so we'll talk more about that soon, perhaps in the next slide, about which medications can cause Parkinsonism. And then we have up here what I think is the most likely diagnosis, and what probably a lot of you picked too, is Parkinson's disease, just good old-fashioned Parkinson's disease. And remember, this is a neurodegenerative disease, and it predominantly affects the dopaminergic neurons in the midbrain, right? And then those neurons project throughout the rest of the nervous system, including the basal ganglia, and you can get effects from that. But the primary disease process is in the midbrain, in those dopaminergic cells. You guys remember the substantia nigra. So Parkinson's disease. Let's see what's next. Yes, this is it. So we talked about how medications can give you a kind of a Parkinsonian picture. Can you identify at least one class of medications or kind of medications that can cause Parkinsonism? So see if you can do it. And if you can come up with more, great. So get your pen, get your paper, get an answer, and then come back. So here we go, two big things that come to mind for me, and as a neurohospitalist I would encounter all the time in my patients with Parkinson's disease or Parkinsonism. The typical antipsychotics. So the one that you're most likely to encounter in this day and age is Haldol. These are the older antipsychotics, very strong dopamine antagonism, and they can trigger Parkinson's findings in patients, even completely normal patients. But for patients who already have Parkinson's or Parkinsonism, it can really, really mess them up. And so avoid those. Instead, what I do as a hospitalist, if I have to give a patient with Parkinson's something for agitation, delirium, hallucinations, I'll use a low dose of quetiapine, which, as you maybe know, is one of the newer antipsychotics. And it has less of that dopamine antagonism. And as long as I'm being careful using a low dose, that usually works out just fine. The other class of medications to look out for is these old antiemetics. So Reglan, Compazine, good drugs. And we're going to talk later when we talk about migraine about a cool thing about these drugs. But not so good if you have Parkinson's disease or Parkinsonism. You want to avoid that, right? And so what you do is you give Zofran, which is a newer antiemetic. And I have not had any problem in those patients with Zofran, nor low-dose Seroquel. There's other medications as well. Okay, so I think, again, if you just cruise through quickly some of these things and just remind yourself what the basic picture is, you'll be fine. You don't have to be experts in these diseases. PSP, progressive supranuclear palsy, is kind of a weird disease. A lot of these are, right? That predominantly affects the frontal lobes, the midbrain, and that's why you get this hummingbird sign with the shrunken midbrain here and the big fat pons on MRI. But look up here, there's a lot of frontal atrophy as well. So this tends to have an older onset in the 70s. Patients can have a lot of problems with their speech. They can have kind of a funny affect where they cry or laugh inappropriately. They have extra axial rigidity. And so, it's not so much their arms and legs that are rigid, it's their axial body. And so they can't bend down. They can't flex their neck. They're rigid like this. They also have terrible balance, dementia, and they can get a gaze palsy. So as the disease progresses, they can first lose their vertical gaze control, so they can't volitionally look up or down, especially down. And then as the disease progresses more, they may lose their ability to move their eyes from one side to the other laterally. So you can imagine these patients fall. They're demented, they have poor balance, they have axial rigidity, so they can't bend down, and they can't look down, so they're set up for trauma. Lewy body dementia, you guys do get a good job of going over this in Foundation, so I'm not going to cover it here. But I'm always impressed by how you guys are able to differentiate Lewy body dementia from Parkinson's disease. It can be kind of messy, and sometimes we're not always right until autopsy, if there is an autopsy. But I think you know that with Parkinson's disease, it's the motor features that really are at the forefront. They come to attention first, and they're more pronounced. In Lewy body dementia, it's more the cognitive stuff, or the cognitive and the psychiatric stuff that comes to the forefront. And then you also have the motor stuff, but that's not quite as severe, at least initially, as the cognitive and psychiatric stuff. As you recall, these patients can have hallucinations, disruptions in their sleep, all kinds of things, big fluctuations in their level of alertness. They can be very, very strange. Essential tremor, I'm not going to talk about this, but remember to review it. Corticobasal degeneration, younger, a little bit younger onset than we usually think of, for some of these other Parkinson's plus diseases. But in that it can happen in people in their 50s and 60s. This is a disease that, as you can see from the name, cortico, can have some cortical kind of findings. And what I mean by that are things like dementia, aphasia, apraxias. You can get an alien limb syndrome, which if you haven't heard or read about, there are actually some videos you can see of people with alien limb syndrome on YouTube. They're quite distressing. And so, the degenerative process looks a little different because of the presence of these things. There's also, of course, basal ganglia degeneration, and so that's why it can look a little Parkinsonian. As is the case with all of these Parkinson's plus conditions, they don't really tend to respond to Sinemet, sadly. So multiple system atrophy, maybe you remember this. There's, basically the basic idea here is that you have this degenerative disease that can give you Parkinsonian findings, cerebellar findings, and autonomic findings. So you get this kind of picture of all of these things in different combinations and different severities. And there's different variants depending on which of the things is more prominent, but they all kind of have some common stuff together. This is a disease worth knowing about if you are going into ENT, actually, or maybe even emergency medicine, in that these patients can sometimes have bad problems with stridor, sometimes actually have to get tracheostomies. All right, so in the end, you decide this patient has Parkinson's disease. We feel good about that diagnosis. We're going to start treatment. So get your pen, get your paper. What treatment are you going to begin? Okay, so what I'm going to do is I'm going to start Sinemet. Some neurologists would argue if you make a diagnosis of Parkinson's and you have a patient who's just starting out with treatment, maybe you save the Sinemet till later and start it later in the disease course because you don't want it to kind of lose its effectiveness over time. But for purposes of me here in this case, and purposes of you taking an NBME exam, if you want to start your Parkinson's patient on Sinemet right off the bat, that's okay. That's very reasonable. So Sinemet, it's a kind of a confusing drug, but basically it contains levodopa, which is a precursor of dopamine. So to get the levodopa to the brain, where it turns into dopamine, we have to get it there first. What happens if you give straight up dopamine is it converts to dopamine in the body, and it makes you really sick, lots of nausea and vomiting. And so that's why the carbidopa is added. The carbidopa, its purpose is to prevent the conversion of levodopa to dopamine in the body until it gets to the brain, so that you get more dopamine in the brain and less peripheral conversion, i.e. nausea and vomiting. So it's a weird drug. It has a short action time. Even the long-acting formulation, patients have to take it several times a day. So it's kind of a tricky medication to take. And it only helps with symptoms. It doesn't help the disease progression. Sorry. Okay, so some other treatments that you'll come across, the dopamine agonists. So you may already be familiar with Requip or Mirapex. They're used for restless leg syndrome. And then the MAOB inhibitors. And then there are other medications as well that can be used for symptoms and such. And then one thing you may encounter this month is deep brain stimulation, which can be very effective for some patients. The medication situation with Parkinson's disease is so complicated. Patients have this really complicated regimen, and then they get side effects from their medications that really cause problems. And so DBS, if it can help lessen the need for medications, it's really a lifesaver for a lot of patients. Okay, case number 2. So now we're kind of shifting gears. We've got a 26-year-old man. He's got sickle cell disease. He is brought to the emergency room by his friend because last night he was complaining of a headache and he went to bed early. But this morning his friend found him confused, vomiting, and still with a headache. So this is worrisome, right? Really worrisome. His vitals also worrisome. He looks toxic. He's got a temperature. He's got tachycardia. He may be hypotensive. I'm going to guess that's lower than his usual blood pressure. And then take a step back. So what do we have here? We've got a toxic-looking lab situation. We don't really know how the patient looks, but the labs certainly look toxic. He's got a headache. He's got fever. He's got nausea, vomiting. He's got mental status changes. Your attending is going to ask you, is there meningismus? So how do we assess meningismus? So you can do these maneuvers that we learn about in foundations, but you can also just feel the patient's head, turn the patient's head from side to side, see if you can passively do that. Can you, flex their neck? Can they do it? Yes. Can they touch their chin to their chest? If you are getting a lot of resistance, or you can't turn the patient and they can't, bend, that suggests meningismus. So let's say we have meningismus. So we've got all of those things plus meningismus. Write down at least 3 things that you're concerned about, and then come back. Okay, so here's some diagnoses. I have to say, for me, my top 3 would be bacterial meningitis, and bacterial meningitis. And the reason is not just that he's got such a good picture for bacterial meningitis, but also I know that bacterial meningitis can kill him. And so I really am having a hard time thinking of anything else until I get him tucked away and covered for the possibility of bacterial meningitis. It's that bad of a disease. Even in this day and age in Seattle, Washington, it kills people. It kills healthy young people. It's rare, but you don't want to have this happen to you. So bacterial meningitis, high on the list. I think we're all there. It could also be viral meningitis. This could entirely fit with viral meningitis. It could fit with a fungal meningitis. Although those kind of tend to be more, sometimes they can be a little bit more slow and indolent. Sometimes they can be aggressive. Thinking about things like cryptococcal meningitis. But think a little bit outside the box. What about something like subarachnoid hemorrhage? Let's say he ruptured an aneurysm and he has a subarachnoid hemorrhage. That would certainly account for the headache, the meningismus, nausea, vomiting, mental status changes. We might also expect photophobia and phonophobia. This doesn't really account for fever, so this is a little lower on our list of diagnoses, but it's an important one to keep in mind because this too could kill our patient, and so we're going to want to make sure we keep this in mind. What about HSV meningoencephalitis? So you remember that HSV can get into the meninges and it can go up to the brain. It likes to settle in the temporal lobes, one or both temporal lobes. And it can cause all kinds of things, memory loss, headaches, fevers, personality changes, seizures, and it can be very, very bad. It can cause permanent brain damage there. So that's an important one we're going to want to keep an eye on as well. You might have learned that HSV meningoencephalitis really is more a disease of older people or immunocompromised people. But there are plenty of young, healthy people who get it too. And then, there's a bunch of other CNS infections that we could consider. We don't really know anything about his immune status other than that he's got sickle cell anemia, and that presents some immune challenges to him. We might also want to know, if none of these pan out, we might want to explore these options a little more carefully and maybe ask about some of these things. So bacterial meningitis in adults. Just to remind you of the microbiology, the biggies for adults when we talk about the bacteria are strep. Strep is by far the most common, and then there's Neisseria and then H. flu. These are all three encapsulated bacteria, and so our patient who's got functional asplenia is going to be at higher risk for all three of those. So other conditions where you're asplenic or functionally asplenic, like having had your spleen removed due to trauma, certain immunoglobulin deficiencies can also cause you specifically for encapsulated bacteria. So there's less common bacteria, so Listeria. So we often think of that when we think of elderly patients, or we think of immunocompromised patients, patients who are kind of frail. But it can also happen in young, healthy people. Maybe you recall that it can actually happen from eating unpasteurized cheese and so forth. It tends to be kind of a slower, more indolent infection. But that's still on the list for this guy. Staph. So staph would be an important consideration, especially if our patient had had a recent procedure or surgery. Maybe he had a spine surgery. He could have got some staph introduced into his meninges that way. Maybe, who knows. But staph is an important consideration for nosocomial infections. Or, infections where there's a breach in the blood-brain barrier due to something like trauma, like a basilar skull fracture or whatnot. And then same with GNRs, gram-negative rods. Those you might think nosocomial, especially you might worry about something like Pseudomonas. And you'd want to know if the patient had had any recent procedures or traumas. Okay, so here's a question for you. So we talked about how patients with sickle cell disease are at a higher risk for bacterial meningitis than the general population. Give me at least 5. I think I've already given you a few, but you can use them. That's okay. If you remember them, you can use them. But I want you to write down at least 5 other things that can be risk factors for bacterial meningitis. So pause and then come back. Okay, so I think I told you a lot of this already. So asplenia, as we discussed, immunocompromised state. So I mentioned how some immunoglobulin deficiencies can do that. Specifically, in the realm of encapsulated bacteria. There's HIV that can predispose you, complement deficiencies. Drug and alcohol abuse, recent surgery or trauma, we talked about that. And then kidney or liver disease, prematurity in babies. There's others. This is not an exhaustive list. I'm sure you thought of others. Okay, so we decide that this is bacterial meningitis until proven otherwise. So what's our plan? What tests do we want? Lab tests, imaging tests, procedures. What treatments do we want? So all of that. Jot that down. Take a few moments. Write down your workup plan, your treatment plan, and then come back. Okay, this is busy, but this is my plan. See how yours compares to this. So ABCs, right? We're going to get this patient tucked away first. He looks septic, at least by labs, and he could be really sick. He's going to probably need some resuscitation. He needs to be on the monitor, all of that good stuff. So let's get him squared away. Then we're going to get some blood, and we're going to get the basic labs. So I want a CMP, I want a CBC, I want coags because I'm going to be sticking a needle in his back. And I want blood cultures. Hang on to that thought, but the blood cultures are really important. And I'm going to give them, notice, well before I do antibiotics. Then I'm going to give steroids. So not everybody does steroids for bacterial meningitis. And in some cases, people consider it kind of controversial. But, if you strongly suspect that this is bacterial meningitis and specifically strep, you know that as you treat the patient with antibiotics, you're going to get an inflammatory response. And in some patients, that inflammatory response can be very damaging. They can lose hearing, can have other problems. And so that's the reason for the steroids. That's what they really help. So if you're going to give them, you're going to give them now. If you're not going to give them, that's fine. Whatever your local culture or your attending's judgment is. In this case, I would give them, and the reason I would give them is because with this story, I'm concerned enough that this man has strep pneumo, and I'm worried about all the morbidity that is associated with that. So I'm going to give him some steroids, and then immediately after, I'm going to do the antibiotics. And here's what I'm doing. So ceftriaxone. In ceftriaxone, here's a little pearl for you that they never teach us until you run into it on accident. But there's different doses of ceftriaxone. And there's a UTI dose. You don't want that. You want the big dose. There's a meningitis dose. It's actually 2 milligrams, Q12 hours. So you want the big dose. You don't want to do the UTI dose. And then vancomycin, and you'll get help from your pharmacist perhaps on the dosing for that. I'm going to go ahead and throw on ampicillin, not because I'm really so convinced this man has listeria, but more because I'm worried that he is really sick, and there's a small possibility he has listeria. I am going to throw it on because the potential benefit outweighs the potential bad. And then, when our cultures come back, maybe we can narrow this down, but for now I'm going to throw on the ampicillin. I'm also going to throw on acyclovir because I'm worried about the possibility of HSV meningoencephalitis too. So I'm going to test for it. If it comes back negative, I'll stop the acyclovir, but for now I'm throwing the kitchen sink at this guy. I want a head CT. Non-contrast head CT is fine with me. We've talked about how, we like to get contrast when we're worried about infection, but, this is an emergent situation, and I don't want to slow anything down. Sometimes contrast, being able to give it, sometimes you get stuck waiting on labs like creatinine and so forth. I don't want any delay, and I don't really feel like I need the contrast that badly yet. Maybe I will, but for now, non-contrast head CT is good enough for me. And I think he needs it, right, before I stick a needle in his back because he's altered. Anything could be going on up here, and I want to make sure it's safe to tap him. Then a lumbar puncture, if it's not contraindicated, because things that would contraindicate you from doing a lumbar puncture would be if there was a big lesion up here that could cause him to herniate if I did a stick from below. So you notice that I don't wait for the lumbar puncture to start the antibiotics. You start the antibiotics as soon as you possibly can. As soon as you possibly can. There's going to be some time between when you order the antibiotics and when they get there from the pharmacy. Use that time to get your blood cultures, and get set up to decide if you're going to give steroids. Okay, so if you guys ever check these out, these videos in clinical medicine from New England Journal are really good. They have lots of them, like dozens of different procedures, and they have videos showing you the best practice. The lumbar puncture video is here, or at least a link for it. It's like 11 minutes. If you are going to be doing an LP or watch an LP, it's worth checking it out. It's a good video. Okay, so we already talked a little bit about some reasons why you would want to image a patient with a CT before you did a lumbar puncture. And certainly one is if they're altered, if they had a seizure, any underlying malignancy that could make you worry that he's got a head full of metastases, focal neurologic changes, in immunocompromised state. So in general, I think have a low threshold to image somebody before you do a lumbar puncture, especially if their exam is not right. So here you go. Get your pen, get your paper. There are, I think, 5 things that we always send our CSF off for. Lab studies that we send our CSF off for. See if you can remember what they are or guess some of them, and write them down and then come back, okay? Oops. Okay, sorry about that. So here, these are the 5 things I send off on almost everybody that I do a lumbar puncture on, probably everybody, realistically, that I do a lumbar puncture on. So cell count and differential. So that'll give you the number of red cells and the number of white cells, and then it'll tell you the kind of white cells and the breakdown percentage of different white cells. And that helps you know, is this viral, is this bacterial, is this tuberculosis? You remember all those good charts. Glucose, so protein, and then the gram stain. Your gram stain will come back pretty quickly. And then your bacterial culture, and that takes a little time to come back. But basically, as you know, you throw on your antibiotics, you wait to see what comes back on your culture, and hopefully that helps you narrow your antibiotics, but it may not. Sometimes that's why we get the blood cultures, right? Sometimes our CSF cultures may not be very helpful, especially if there's been a long delay between when we started the antibiotics and when we got the CSF. We might have sterilized our fluid, our spinal fluid. So in that event, sometimes the blood cultures that you got earlier before antibiotics can save you. In this guy's case, I'm going to also, as I mentioned, throw on the HSV PCR test. And then if that comes back negative, I'll stop the acyclovir. Okay, last case, quick case. We've got a 79-year-old man. He's hypertensive. He's got stroke risk factors, right? Hypertension, coronary artery disease, hyperlipidemia. He's diabetic. He's eating with his wife one morning, and he suddenly has trouble. So he was asking her to pass the salt, and then he couldn't say it. He just could say salt, salt, salt. So he kept repeating that, and you could tell he was frustrated. He knew something was wrong. And his wife noticed that the right side of his face looked funny, and he couldn't move his right arm. His right arm was just kind of hanging limp at the side. So she called for help. Medics arrived, and he was hypertensive, 170 over 110. And then the medics get him in the rig, and in the rig, on the way to the hospital, he returns completely back to normal. And so he's just his usual normal self. Gets a totally good, normal, benign neurologic exam in the emergency room, and gets a CT scan that shows no acute changes. So what is the diagnosis? What's the most likely diagnosis? We don't need to come up with a big differential here, but what is your most likely diagnosis? And where does it localize? What part of the brain gave him those symptoms? So difficulty speaking, right facial droop, lower, right arm weakness. Okay, so this was probably a left MCA territory, TIA. So if you recall, the things that you can get in a left, i.e. dominant hemisphere stroke or TIA are the following. If you had you may already know that the majority of people are left brain dominant, especially if they're right-handed. There's some very small proportion of people who are left-handed who are right brain dominant. But it's really rare. So the vast majority of us are left brain dominant. So anyway, so the things that you'll expect to see if somebody has a left MCA stroke or TIA, aphasia, usually a non-fluent aphasia like our patient had where he's struggling for words. You may see a gaze preference, and we'll talk about this later perhaps, but a gaze preference, you maybe recall hearing this expression, look toward a stroke, look away from a seizure. Our frontal eye fields drive our gaze from one side to the other. And if we have frontal lobe damage from something like an ischemic stroke, we can get deviation toward the side of the lesion. We'll talk more about why that happens later. The other things that you would expect with a left MCA syndrome is right lower facial weakness, so just down here, not the upper part of the face. And then weakness, that's much worse in the arm than the leg. So think about your homunculus, so the MCA territory. So that includes the face, the arm, the hand. But the motor cortex for the leg is on the medial aspect of the brain, and its blood supply is the anterior cerebral artery. So why would we even get any leg weakness in an MCA stroke to begin with? Well, the reason is because those fibers that leave the frontal lobe, the leg motor cortex area, still have to descend through the corona radiata and the internal capsule, and those get their blood supply from the MCA. So the upshot is that if you have an MCA stroke or TIA, you can get a bit of leg weakness. You should still be able to walk, but you're by far weaker in the arm. You may also get some right-sided hemisensory loss due to the parietal lobe involvement. So what did this guy have? He had a TIA. So what are his chances of going on to have a completed stroke in the near future? So you may have seen about this in the video, the ABCD squared score. I don't care if you remember this score. If you're going into emergency medicine, it's probably a good thing for you to know. But otherwise, I don't care if you don't need to memorize it. But you should have a sense that TIA is an emergency. And you should have a sense of what kinds of things make this a high-risk TIA. And you should also know what to do with a patient who has a high-risk TIA. So here are the features of this score. And it's basically older age, higher blood pressure, and then the clinical features. You know, if he came in saying, oh yeah, my arm was numb over here for a while. It was just kind of numb. I could talk fine, I could move fine, but I was numb here. That's less worrisome than a hemiparesis, right? And so the quality or the nature of your symptoms is important. And if you have a unilateral weakness or you have a speech disturbance like our patient did, that's a high-risk situation. The duration of the symptoms, you know, if it just lasts a minute, that's not as severe as if it lasts over an hour. And then the presence of diabetes in this particular scoring system, because diabetes is such a huge risk for stroke. So he scores a 6, which is pretty high on the ABCD squared score. It only goes up to 7. So according to that, his 2-day risk of stroke is 8%. His 7-day risk of stroke is 11%. His 90-day risk of stroke is 17%. So he's a high-risk person. I should back up and tell you, scores like this, the ABCD squared score, again, the vast majority of you will never see this, never need to see this again, but say you're going into emergency medicine. If you want to access something like this, there's all kinds of calculators on the web, and it'll give you references to the articles. In this case, there was a particular article that this was based on, if you want to see the primary data. So yeah, so this is the idea with TIAs, is that the more risky, you know, the more points on this axis here, the more points you get, the higher your risk of stroke. And that continues over time, right? So our patient here, look at that. His risk is high now, but it's high, you know, as we go out too. So we got to fix this, and we got to fix this fast. So here we go. How are you going to manage this patient? I want you to pick one of these two options. So A, yeah, he's high risk for stroke, so we're going to admit him to the hospital, and we're going to do an expedited workup. We're going to monitor him, just because he could have a stroke right there and then. And if he does, we can do whatever we need to do. We can give TPA, we could do a thrombectomy, whatever. So your alternative choice is say, yeah, his risk is high, but it's expensive to be in the hospital, and he looks good now, so let's do this as an outpatient. He can go get his MRI, he can go get his cardiac echo, and then he can get his lipids, and then he can go see his PCP who can refer him to a neurologist, and you get the idea. So make your best pick. Which is the better way to go? Okay, yeah, I would admit him. So my policy is to admit patients who have especially high-risk TIAs, because they're at high risk, and there's a lot that you need to get done, and you know how hard it is to get things done on an outpatient basis in a fast manner. So TIA is an emergency, and it should be treated aggressively. Offer admission to high-risk TIA patients. Now, some cities have TIA clinics. We don't really have anything like that in Seattle, but there are some places where you have slick, you know, TIA clinics that can get the job done quickly and may help you avert admission. But if in doubt, err on the side of caution and admit. And then just, you know, these are some of the things that convey a higher risk. So that is it. I will see you for the next video next time, and good luck, okay? Bye-bye.